So, you just started using LinkedIn Premium. Now what? Well, on your premium company page, you noticed around 7.5 times more page engagement and 5 times more page views. Well done. And now, new clients are messaging you. All because you're using LinkedIn Premium, which helps you get the business growth you want. Think big, small business. Think big. Start your free trial at linkedin.com/premium small business. That's linkedin.com/premium small business.
At Capella University, you can learn at your own pace with our FlexPath learning format. Take 1 or 2 courses at a time and complete as many as you can in a 12-week billing session. With FlexPath, you can even finish the bachelor's degree you started in 22 months for $20,000. A different future is closer than you think with Capella University. Learn more at capella.edu. Fastest 25% of students. Cost varies by pace, transfer credits, and other factors. Fees apply.
This is Addiction Medicine Journal Club. I'm Dr. Sonya Tredici.
And I'm Dr. John Keenan.
We believe that addiction is a disease that can be treated, and we want to help you stay up to date with the latest research that you can use in your addiction medicine practice. This podcast also offers Category 1 CME credit through MyCares and Michigan State University. The links for the CME are in the show notes. So this week, we are going to be discussing using stimulants to treat methamphetamine use disorder. How are you doing, John?
I'm living the dream, right? It's 9 p.m. on a Wednesday night after a 13-hour clinic day, so I'm just filled with energy.
You're going to do amazing. Yeah, I'm feeling pretty good, too, because I just had a Dairy Queen Blizzard, so that really gives you a lot of extra energy, especially late at night. So I think it's going to be a good one.
Or you're going to crash halfway through.
From the
just
sugar.
Take a nap.
John, are you thinking about anything in addiction medicine news this week for our listeners?
Yeah, I mean, I think with like a current climate going on in the world, I kind of wanted to pick something that was just kind of, I thought, interesting and kind of fun to hear about. So I saw this article from the New York Times, and it was called "The People Who Never Get Hangovers." And it's interesting. When I was studying for our addiction medicine boards and fundamentals of addiction medicine, they talk about like what is a hangover, and the pathophysiology of it is probably a combination, or at least it was thought at the time, of dehydration, glucose depletion, buildup of lactic acid. But actually, this article talks about like existing research that about a quarter of people report, even with heavy drinking, they've never experienced a hangover in their life, which I thought was very surprising to me.
Huh?
Isn't it?
Do they say why?
Well, no, they then it's a very high level overview article about kind of like different factors that they've studied. Clearly we know genetic association with aldehyde dehydrogenase metabolism plays a factor in how some people metabolize alcohol. But also they talk about there's just kind of genetic predispositions for certain factors that probably metabolize quicker. But then they also thought, so genetic variability is certainly something I think makes a lot of sense. But then I thought it was really kind of cool that they actually talked about psychological factors associated with the development of a hangover. And they've shown that like people with high degrees of neuroticism, they're more likely to experience a hangover after drinking, that people that go into a bar or a setting are more likely to experience a hangover than people that drink at home. They talk about how, clearly pace and the amount of alcohol also come into play. But I thought it was interesting that like kind of also like a person's expectations and the place of consumption has a factor, or at least there's studies showing that.
Well, and I think, doesn't that also, I've seen studies where even if you give people non-alcoholic drinks, but tell them they're alcoholic and give them enough to get them drunk, they feel drunk and act drunk, even though they haven't had any alcohol.
Yeah, actually, one of my friends was in a frat, and they did that to them. They made them drink a keg of a Duels. And apparently a bunch of them were acting like they were really drunk.
Well, you're not just pretending, like you really feel it. The brain is an amazing organ.
Yeah. How about you? What have you been thinking about?
Well, it's not really news, but I had a really novel case a few weeks ago. I don't want to be too specific about the patient, but they were coming to me for help with an addiction to a compound called Tianeptine, sold under the brand name Zaza, or otherwise known as gas station heroin. Just, if something's called gas station heroin, it's definitely a problem. And how I know it's really bad is I went to talk to my neighbor who owns a tobacco hut at the end of my street. And I talked to him about kratom and, he's my buddy now. And he said he wouldn't sell it because it's too dangerous and he doesn't wanna kill anyone. And this is from a guy with, like, 1,000 square feet of retail space dedicated to tobacco products and kratom. So if he won't sell it, it's definitely like, you definitely know it's bad. Basically, it's an antidepressant, an atypical antidepressant. It's not really an SSRI or a TCA. It is for sale, like, as a prescription pharmaceutical in some countries in Europe, but they don't really know the mechanism of action. It interacts with serotonin and glutamate receptors, but at high doses, it interacts with the opioid receptors and acts like a mu opioid agonist, and becomes very addictive. So my patient was taking 45 to 60 capsules a day. The prescribed dose is 1 to 2 capsules a day, so massive amounts, and this patient couldn't stop, went into terrible debt for the product, because it's $40 a bottle, and they were taking 3 to 5 bottles a day. Couldn't function at all, couldn't sleep, couldn't work, and then terrified that it was gonna become illegal and they'd lose their supply and having horrible withdrawals whenever they tried to stop. So, like our deal with kratom, there's not a lot of data on it, but, some people have used buprenorphine with success, so that's what I tried with this patient, who did well in it, at least for the first 2 weeks, which is as far as we've gotten so far, which is where we are. So, John, have you ever seen this, Zaza or Tianeptine?
I've heard this talked about by patients. I've never seen it. I've never dealt with a case like this. It's kind of very interesting that we've got this whole new complex of diseases from like quote legal, like alternative medications. I guess is how these are alternative treatments is kind of how this is branded.
Yeah.
Interesting.
Well, right, there's this, like, shadow economy of addictive compounds that haven't been made illegal yet, but are still quite unsafe. Or I think like alcohol, safe at low doses, but unsafe at high doses, or like the kratom again, like a lot of people appear to use it for, with just, better living through chemistry, right? But at high doses, it becomes unsafe. And it's like, where do you draw the line in terms of making it illegal? But this definitely should be illegal. Even Tobacco Hut won't sell it.
Well, I mean, and okay, and their ethics are well known. But it is interesting though, like how all these kind of like opioid like products are getting approved and on the market, right? I feel like it's interesting that they're all like opioid like, they're all opioid receptor agonists or partial agonists, and yet they seem to be sliding through, and they're basically like backdoor opioid use disorder is what these are.
Right, and just to, not to correct you, but, like, they're definitely not approved. Like, they
Well,
haven't been made illegal, but it's like they don't go through any testing. They're just sold, and it's like,
sorry, I misspoke.
yeah.
More so that it's available to buy, right?
Well, right, you can just, like, buy it at a store, a gas station. But yeah, if any of our listeners have experience with that, I would be very interested to hear what people have to say, and I'll put a link. There's, like, a review article about it, with the information that is available. I'll put a link in our show notes.
Yeah, it's like Mad Libs. If you put gas station with like any noun behind it,
It's
you're in for something, right?
right. It's definitely not good. Oh, John, are you ready to, talk about your article?
Yeah, so like I'm kind of excited to present this article because this is a topic where I feel like I anecdotally I hear a lot of other people that kind of work in the addiction medicine circle. They talk about kind of using amphetamines or stimulants off label for um, methamphetamine use disorder. And every time I hear it, I'm always like, I'm always a little bit surprised. Like, I'm like, you're doing that as kind of like how I respond, just because I didn't really see this as having much evidence behind it before. And certainly I see that quite a bit of anecdotal case reports are available. It is in the textbook Fundamentals of Addiction Medicine as kind of like an ineffective treatment in the section about like methamphetamine use disorder and stimulant use disorder. But this is an actual like randomized placebo controlled trial. So kind of more than our average kind of anecdotal case report series.
Right. Well,
And the articles,
oops. I don't mean to interrupt. It's just, like logically, we're so comfortable with using agonists to treat substance use disorder, like with nicotine and opioids. It's kind of like, why wouldn't a stimulant work? Tickle the same receptors, but be legal and safe, seems like a great idea.
It does sound like in the realm of a methadone program, right? So the article is called Lisdexamfetamine Treatment of Methamphetamine Dependence. It's a randomized placebo-controlled trial, and it's from Addiction, December 2024. So a little bit about backgrounds for this condition. 36 million people worldwide use amphetamine-type substances, including methamphetamine. Methamphetamine use leads to physical, psychological, social harms, and increased mortality associations are noted. Psychosocial interventions such as cognitive behavioral therapy improve treatment retention with strong evidence supporting contingency management in the United States. However, the effectiveness is limited, and basically, a lot of patients don't have access to this. And for those of you that maybe aren't kind of practicing addiction medicine, contingency management is where patients present to clinic, and there's a some sort of reward for negative drug testing results for a substance, and you get rewarded for it, often monetarily. It's not a ton of money, but it's a little bit. There's currently no FDA-approved drugs for methamphetamine use disorder, but I think all of us in the field definitely have tried pretty much everything off-label to see if we could get something to stick in this domain. Lisdexamfetamine, and it's also kind of under the name Vyvanse. This is a prodrug of amphetamine, and so basically, it's a really nice potential treatment target. It has a slow onset of action. It's a prodrug, so it can't be kind of crushed up and misused as easily as a pure amphetamine. And so it's kind of thought, due to the long duration of action and these feelings that it can't be misused as easily, this would be a great possible candidate for treatment. Data has shown that higher doses of lisdexamfetamine, 100 to 250 milligrams, may be needed for methamphetamine dependence compared to other conditions like ADHD. To give you an idea, that's a very high dose compared to ADHD. So, like in ADHD, you're talking about like 20 to 70 milligrams of lisdexamfetamine. So this is really up to like 4 times what they're talking about for maximum doses for the conditions like FDA-approved ADHD. Pilot studies and recent withdrawal studies show that doses of 100 to 250 milligrams are safe for this population, with no safety concerns of 250 milligrams of lisdexamfetamine during short-term follow-up. So kind of patients exposed to this, even at these higher doses in these short-term trials, there was no safety events noted. What's the clinical question? One, does lisdexamfetamine reduce methamphetamine use in individuals with methamphetamine dependence compared to placebo? And 2, is lisdexamfetamine safe for use in individuals with methamphetamine dependence? So does it work at reducing use, and is it safe? What do you think about the question so far, Sonya?
2 good questions. Those are the 2 things I wanna know.
Yeah. So a little about the study design. This was a randomized, double-blind, placebo-controlled phase 3 trial to evaluate oral lisdexamfetamine, 250 milligrams daily for 12 weeks in reducing methamphetamine use. The study included 164 participants with methamphetamine dependence recruited from 6 Australian clinics. The study featured a trial design of 1-week induction, 12 weeks of maintenance treatment, a 2-week taper, and then follow up to week 19. So it's a total of 19 weeks of follow up. As we talked about, there's 164 participants that met criteria for methamphetamine dependence. Inclusion criteria was that they had to meet ICD-10 criteria or DSM-5 criteria for methamphetamine dependence. They reported use of methamphetamine on at least 14 out of the previous 28 days. They had at least 1 urinalysis positive for methamphetamine. Exclusion criteria would be a known contraindication for lisdexamfetamine. So that would be anything that would be a typical stimulant contraindication, excluding stimulant dependence. They didn't count that as a exclusion criteria. If you're on a current opioid agonist, that would exclude you from this trial. If you had current severe psychiatric or other medical disorders, that would exclude you. If you were dependent on alcohol or other non-prescribed substances, use of another prescribed stimulant, so they gave the example here of methylphenidate or amphetamines, unavailability for follow-up, or if you were in a court-mandated program for like child protection or work-mandated drug testing, you were not eligible for this trial. So in terms of the primary outcomes was the number of self-reported days of methamphetamine use in the past 28 days at the end of the 12-week maintenance period. So at the end of the trial of the actual intervention, how many days were you reporting methamphetamine use over the past month up to that? And this was done by timeline follow back. Secondary outcomes were total number of days of self-reported methamphetamine use during the 12-week treatment period, so days 0 to 84, the longest duration of abstinence during the treatment period, percentage abstinence on 21 days or greater, so how many people met more than 3 weeks of abstinence during the trial, percentage of methamphetamine negative urine tests over 12 weeks. Any missed data was assumed to be a positive. And then self-reported abstinence when it was validated by a urine drug screen. So they basically wanted to see if like the self-reports were kind of correlated with the samples they obtained. They measured a lot of other stuff. So they had a visual analog scale for cravings, an amphetamine withdrawal questionnaire, a severity of dependence scale, the timeline follow back, insomnia severity index, drug effect questionnaire, the depression, anxiety, and stress scale, the DAS-21, the PHQ-15, the World Health Organization Quality of Life, BREF, the Treatment Retention Scale, the Opioid Treatment Index for injecting, Opioid Treatment Index for crime, Treatment Satisfaction Questionnaire for medications, the Wender Utah Rating Scale for childhood ADHD. This one's important. I've not heard of this before. Have you, Sonya?
Mm-mm.
Yeah, it's basically a scale that kind of for people to assess whether or not they had ADHD traits in baseline. I don't see this administered often when I get my neuropsych reports back. So I'm wondering if it's more prevalent overseas, but that's kind of an important piece of data they talk about.
I feel like I should get that scale because, I have people who say, yeah, I had ADHD as a kid, but they can't really describe what that means.
Yeah. The Enriched Social Support Index and the demographic data was obtained. Adverse events were classified based upon organ system and class using the Medical Dictionary for Regulatory Activities. That's the MEDRA reporting classification. I want to take a couple minutes here, or hopefully just a minute, to overview like the study protocol to walk you through exactly what they did. So week 1, they had a baseline daily visit, day 1 to 5. Subjects were randomized 1-to-1, and they were stratified by treatment sites, so 1-to-1 at the different treatment sites. They received a lisdexamfetamine induction of 150 milligrams daily for 1 week. During that time frame, they received supervised medication administration, urine drug screens, vital signs, and adverse effect data was collected. They did medication reconciliation, adherence counseling, and they did self-reported methamphetamine use collection. There were safety measures, including assessments for psychosis, suicidality, and an ECG. For weeks 2 to 19, they went to twice weekly visits, and this was supervised medication administration, or at least it was initially planned to be supervised medication administration. And so basically, starting on weeks 2 to 13, you basically got 250 milligrams daily. So you went up from that 150 to 250 during your treatment period. At the end of that 12-week trial, you went down to 150 milligrams for a week, then 50 milligrams for a week, and then the last 3 weeks of the trial, or last 4 weeks of the trial, you were kind of had no medication whatsoever. They did urine drug testing once per week. They collected vital signs. Adverse events were documented and evaluated at these different follow-up visits. They did a medication return, reconciliation, and adherence protocol where they were initially planning to kind of review how much medication you took and then kind of give you adherence guidance. They did self-reported methamphetamine use for the week prior to each of these visits using the timeline follow-back questionnaire. Throughout this trial, the 19 weeks, there was 4 different visits that were also very long. These were extended research visits. So it was week 5, 9, 13, and 19. And at this time frame, they also did a comprehensive health evaluation. They did the extended safety screens for psychosis, suicidality. They did the repeat cardiac monitoring with the EKG. And actually, you got reimbursement. So you got $20 at baseline, and then each of these visits, you got another $10 on top of that. So $20 for visit 1, $30 for visit 2, $40 for visit 3, up to $50. So that was kind of the reimbursement part, just for kind of continuing to show up. Unfortunately, this trial was done during COVID-19. So the trial design was really good. The problem is that with kind of COVID-19 restrictions, there was different compromises that had to occur throughout the trial duration. So in April 2020, in-person visits were reduced to every 2 weeks. They only had 1 supervised dose and up to 13 for self-administration. So really, this kind of self-administration part of the protocol was kind of let go in order to keep people from cohorting so often. Data collection occurred via telephone, and they had basically unsupervised urine drug screens that were obtained. There was face-to-face assessments were limited, and then they stopped doing EKGs for evaluation. In October of 2020, the visit was reduced to 2 induction weeks and then weekly after, or 2 visits the first induction week and then weekly thereafter. They had daily self-administration with sufficient medication dispensation. So basically, it was more like take-homes were at that point going forward. And they did urine drug screen samples just once per week at that point in time. They did kind of statistical analysis, kind of like looking for unblinding, and looked at the clinical side as a random effect. So basically, they looked at anyone that had at least one dose were analyzed according to this. And they also looked at treatment allocation differences by site. So what do you think of the trial so far?
I think it's good. I have a question for you though, and this isn't a question we discussed ahead of time. So if I'm putting you on the spot, I apologize. Um, I'm wondering if there was any kind of inclusion criteria that people had to want to be quitting methamphetamine to be in this study, like people desiring to quit or cut down or not. Because it's like, I just think about all these treatments for methamphetamine use disorder, same with alcohol use disorder, tobacco use disorder. Like the treatments don't make you stop using, they sort of make your quit attempt easier. And so I'm wondering if these people didn't like wanted to stop or didn't care. And if they didn't care, it would be less effective than if this were sort of an adjunct to a more like comprehensive program to get people off methamphetamine.
Yeah,
So
that's a really, really good question.
and I don't, because it wasn't in the inclusion criteria, that you had to that you actually wanted to quit, but maybe there's something that I don't know, or if you're a researcher on this paper, maybe you could let us know what your thoughts were on that.
I didn't see where that was mentioned that they actually kind of wanted to quit, to be quite frank. It's basically they were recruited through local clinics and online advertising. So I didn't really see where a desire to quit is actually part of this whatsoever.
Yeah.
You just had to be using methamphetamine and
Well,
want to be included in the study.
well, right. I wonder if there'd be people in the study who didn't want to quit at all, who were drawn by the either monetary reimbursement or the promise of getting the I can't say it, the prescribed amphetamine on top of everything else.
Yeah. So is this trial valid? So the study was funded by the National Health and Medical Research Council, St. Vincent's Coran Foundation, multiple other kind of public health and university programs. So really kind of no industry funding whatsoever. Several of the authors did report financial honoraria from organizations such as NHMRC, Indivior, AbbVie Australia, Pfizer Australia, and Cameras AB, but they were unrelated to the current study. This was, like I said, a relatively large size, 164 participants, randomized, double blind, placebo controlled trial. So, like, I actually love the way they set up the trial. I felt it's kind of a bummer that the COVID restrictions caused them to make some compromises. I mean, they had to do it, right? We were all there during the time frame. And so, I mean, it just is kind of unfortunate because I think that would have really been additional information that would have been really helpful.
Yeah, for sure.
I do think that the relatively strict exclusion criteria does really narrow this quite a bit, right? I think that the concurrent opioid agonist therapy, polysubstance dependence, psychiatric illness, that really kind of like limits generalizability of this quite a bit. So you're looking at kind of just methamphetamine use disorder, like in its purest form. The trial duration was relatively short. So I think 12-week intervention with follow-up to week 19. I think that's really, not probably great sufficiency in terms of like determining how long-term harm this or how much long-term harm is actually associated with these, and also how effective are these in the long term. I think oftentimes with stimulants, once they're started, right, once you kind of get an indication, it's just kind of assumed everyone else is going to continue it in many regards. Um, and also, we do know that, like, especially with ADHD, we know that long-term stimulant use at this point does increase risk of cardiovascular disease and does have kind of a slight increased risk of mortality with long-term use. I know that was controversial at one point. There are many larger studies now showing that that's not a theoretical harm. In fact, I do counsel my adults about that at this point, that there's a slight risk there.
Mhm.
Um, The study had moderate retention, 57% of participants completed, which basically meant that, the statistical power was relatively low in terms of detecting smaller treatment effects. So that could have limited what the study could have been just by the treatment retention alone. Another thought that the authors brought up was that during COVID and during a pandemic, there's a lot going on that's outside of the control of the trial, right? So there's difficulty in terms of like border shutdowns, supply chain issues. So like actually, your drug supply and patient behavior changes substantially. So this also may not reflect like currently like in vivo situations that we would see in our practice with patients with this disorder. Um, Both self-reported for medication adherence and, and methamphetamine use, along with discrepancies in urinalysis periodicity, may have introduced bias and making it very difficult to verify like participant data. So I think it's really difficult with sometimes when we're able to obtain quite the same amount of data. Could you correlate those two quite as well? 39% of participants in this actually screened positive for some form of ADHD in childhood. So with this WERS questionnaire that I talked about earlier. So I think there's a thought that, that this group has a high possible ADHD component, the trial group. So the question is, were you really treating ADHD or methamphetamine use disorder or both in this trial? The fixed dose design didn't allow any individualization. So really, basically everyone was assumed to have the same one. So there could be very many scenarios where people would possibly require less or more lisdexamfetamine. So like it was a trial where you only gave them that one option. I find that blindings, and this is like almost like the semaglutide article. I feel like blinding for an amphetamine is really difficult, right? There's a very high placebo effect with it. I pulled up the chart for the medical student the other day that kind of methamphetamine has a effect of 1,000 times baseline dopamine levels compared to something like, for example, eating a really good dinner, which is 150%, sex is 200%, but methamphetamine is up there 1,000 times. So I feel like it's hard not to know that you're on that.
Yeah, I can't even imagine what the placebo could be that would, like, I don't know.
I think it's a hard placebo, right? Evidence from from the adult ADHD population really shows that, perception of effectiveness by patients isn't always accurate as terms of functional outcomes. So, like, I didn't know this until I went to a kind of recent grand rounds about adult ADHD by one of our local tertiary care hospitals. But, there is evidence that people on stimulants, they have a high perception that, the treatment is much more effective than it actually may be in reality when you look at objective measures. And so that it's really good to kind of keep that in mind that there is a high patient satisfaction, which sometimes confounds any self-reported outcomes with these medications. The lack of statistically significant adverse effects, including really any cardiovascular effects in this trial, it really also causes me to question if the study was adequately powered or had adequate duration, especially with the fact that we know that these are effects at this point. So the fact that neither one of those were found when we get to the results also leads me to believe it would be great if it was a little bit longer.
I guess that doesn't bother me so much because if I think about the adverse cardiovascular effects of being on like illicit methamphetamine, I feel like this lisdexamfetamine would be so little compared to that I'm not surprised that it didn't show a difference in cardiovascular outcomes. Also short term, but like I think it's probably going to be like if it were effective, it's like opioids. Like there are side effects of being on buprenorphine and methadone, but compared to being on fentanyl, it's just so much better. You know.
Yeah. So here's kind of the results here. So a little bit about the participants. So like 164 out of 234 were enrolled. So 70% that were screened were actually enrolled. They were mostly male, 62%, a mean age of 39. There was 84 participants in the placebo and 80 in the control group. Baseline methamphetamine use was a mean of 23.7 days in the previous 28 days. Almost 40% had greater than or equal to a 46 on the WERS, indicating childhood ADHD symptoms. So just short of half of the patients. 155 participants received at least one dose of medication or placebo. There was a 39% attrition rate throughout the trial. 118 participants enrolled pre-pandemic and 37 post-pandemic. Interestingly, there was a minor difference in the pre and post-pandemic in that the post-pandemic cohort showed increased university-educated participants, and they actually had a higher rate of gay men in there. So that was a little bit different, but otherwise they were relatively the same.
These people are using so much methamphetamine. Like, if you assume that the people who dropped out of the study were somehow doing clinically even worse, maybe that's a wrong assumption, but that's usually my assumption. That on average, people were using, 24 out of 28 days. It's like almost daily methamphetamine use. And those are the people who were, motivated enough to stay in the study. It's a lot of methamphetamine.
All right. So there's a lot of stuff they went through. Here's a lot of outcomes. So I'm going to go through them. And at the end of it, I'm just going to summarize again the ones that were significant. Okay.
All
Are
right.
you
I'm
ready for
ready.
this? All right.
I'm
all right.
ready.
So primary outcome, there was no significant difference in the daily probability of methamphetamine use between lisdexamfetamine and placebo group over the 28 days prior to week 13. So there was a slight change, but they said it might be correlated to about an estimated 2.2-day reduction in methamphetamine use compared to the lisdexamfetamine group. Secondary outcomes in terms of methamphetamine use. The lisdexamfetamine group had 8.8 fewer days of methamphetamine use over 12 weeks compared to placebo. There was no sustained difference in methamphetamine use in follow-up at week 19. So when the medication was reviewed, there was no change. There was no statistically significant differences in continuous 21-day abstinence, longest period of abstinence, proportion of negative urine drug screen tests, cravings, withdrawal, severity of dependence. In terms of treatment effect, there was no significant differences in a treatment effect at week 13, and there was no significant difference in treatment effect by pandemic status, childhood ADHD status, or social support. In terms of treatment satisfaction, the lisdexamfetamine group had significantly higher scores for perceived effectiveness and higher global satisfaction of the product. There was no significant differences in side effects or convenience between the two. In terms of general health and quality of life, there was weak evidence of better health-related quality of life in the lisdexamfetamine group, but it was not statistically significant, so it was just shy of statistical significance. In terms of adherence, there was actually no significant between-group difference in adherence to supervised doses between the groups. In terms of extra medical use liability, so this means like how much do they like the medication, how much do they pay for it. There was higher drug liking scores in the lisdexamfetamine group. There was a higher perceived similarity to methamphetamine in the lisdexamfetamine group. And there was a higher price that participants were willing to pay for the study drug in the lisdexamfetamine group than the placebo.
Well, and that goes along with it. People they could tell what they were taking, placebo versus the active compound.
In terms of other drug use, there's no difference between drug use between the two groups in terms of other drug use. In terms of days of methamphetamine use over a 12-week period, there was a statistically significant decrease in days of methamphetamine use, 43.8 versus 52.7 days over the 12-week period. In terms of the longest period of abstinence, there was no between-group difference. In terms of cravings, there was no significant difference. In terms of withdrawal, no significant difference. In terms of severity of dependence, no significant difference. In terms of adverse effect, there was no significant difference in any adverse effects except for slightly more nausea in the lisdexamfetamine group, 16% versus 5%, and there was a slightly higher diastolic blood pressure reading in the lisdexamfetamine group at week 8 or week 5 and 8. So a lot of stuff there, but basically, if I were to summarize it, throughout the trial period, the statistically significant findings were that there was about 8.8 fewer days of methamphetamine use over a 12-week period in the group that got lisdexamfetamine. Patients on lisdexamfetamine, they thought it was effective. They liked it a lot. They were willing to pay more for it. And they had slightly more side effects, only really nausea, but not any real cardiovascular outcomes. What do you think about that?
I mean, I'm a little disappointed it didn't work better. I would love this to be, an agonist that would help people stay off methamphetamine. So I'm disappointed it didn't work better, but I don't wanna say it wasn't a good study, like, I think it was good, like, the setup was good, but I feel like the challenges, like you pointed out, were so great that it makes the results not necessarily valid, so I'm not ready to call it on, like, this not being effective, between, like, the high dropout rate and the pandemic killing all their study visits and I don't know, the unblinding, um, and I think honestly the fact that I didn't see patients necessarily wanting to quit, you're sort of taking this along with using as much methamphetamine as you want and hoping that it will make you quit. Like, I don't know if that's the most effective way to use this product. Um, I think for people who are highly motivated for abstinence or even just partial abstinence, if they took something like this, would it really help them get to that goal? So I do feel like there's a different study in another context that might show a better result.
Yeah, I think like as a primary care doctor that practices addiction medicine, I think all of us are really struggling with methamphetamine use, right? I feel like it's like the thing that we all see every day and we have the least to offer right now. And most of us, except for those that are like in a full-time addiction medicine practice or program, probably don't have access to contingency management. I feel like I've thrown the kitchen sink at this thing. I think like, topiramate, off-label low-dose mirtazapine, bupropion, naltrexone. And I feel like I've been underwhelmed by anything that I have to offer to date.
Yeah.
Do you agree or disagree with that?
I totally agree. Nothing works that great. Um,
Yeah.
so I wish there was a magic bullet medication for people.
Yeah. And so like you're right. I'm not ready to hang this one up on the shelf entirely. I think it could be a possible promising target. I think it's just hard for me to say that this is going to be practice changing at this point for me. I certainly wouldn't do this. I do. I'm one of the few doctors I have prescribed stimulants for ADHD and my kind of substance like patients that have like dual diagnosis. And I will tell you, it is a very very sticky situation at times. I feel like um, it's not the same. There's misuse comes up very frequently, and it creates very difficult treatment situations at the office.
Yeah, well, and especially since it doesn't actually apparently work to treat methamphetamine use disorder, we're still left with the indication of adult ADHD, which in and of itself is a kind of, can be a hard diagnosis to make. And then if you have overlying stimulant use disorder, it's pretty hard to assess for ADHD in that situation to know whether stimulants would be appropriate.
Yeah. We'll see. I mean, TBD. I think not yet ready for prime time.
They didn't show a lot of harm, so that was good.
Yeah.
That's all we got.
I mean, no,
What
there's slight improvement, right? I guess the question is in 12 weeks is 8 fewer days worth prescribing a super therapeutic dose of lisdexamfetamine? I mean, that's kind of the end question. I mean, and that might be different from patient to patient, right?
right. But given that people were using it almost daily, like 8 out of 84 days, it's about like, I don't know what percent reduction, but 10, 15% reduction in use. Is that worth it? Especially if you think there might be some cardiovascular risks and I don't know. It's not really the outcome the patients would want necessarily. Like people who are trying to cut down, we've talked about this with alcohol. People don't necessarily want abstinence. They just want to cut down, but they don't want to just cut down by like 10%.
Yeah.
They'd want to cut
All I'm
down.
saying is that, people come to us on very different scenarios, right? We have very diverse set of patients and patient needs. I could imagine somewhere, somehow, a patient may present where cutting down 8 days may actually be something that's desirable.
Yeah, sure.
I don't know. I'm sure that close your eyes and imagine it.
Yeah, right, right. It's true. It's true. I can imagine that person.
Okay.
Oh my gosh. Well, John, thank you so much for presenting that article. I did have some talk back from one of our listeners I wanted to share with our audience. We got a very nice email from listener named Shannon Boosted, a family doc and addiction medicine specialist in Washington. And she wrote to us about our Kratom episode, which was episode 50, which we did a few months ago. And here's what she said. She said, I wanted to flag something that came up recently in clinic, which I think connects to the complexities you've discussed around kratom. I had a patient who struggled for months to transition from kratom to buprenorphine. After learning more about kratom's constituents, I asked what product he was using, and he said 7-Star, which claims to contain 7-hydroxymitragynine. I hadn't realized how different 7-OH, the 7-hydroxymitragynine, is from the natural mitragynine. From what I understand, it's a semi-synthetic, potent mu opioid receptor agonist and seems associated with higher risk for dependence and withdrawal. These novel semi-synthetic 7-hydroxymitragynine products pose public health risks due to the unknown chemical constituents and the known pharmacology of the 7-hydroxymitragynine. Clinicians must screen patients for their use, and policymakers must distinguish between kratom and this 7-hydroxymitragynine. So, Dr. Boosted, we agree with you. These synthetic psychoactive compounds bear very little resemblance to the original botanicals, although they try and sell themselves as something natural and safe. But as soon as the chemists, the biochemists and the capitalists get a hold of these things, they are no longer the, kind of safe natural product that they once were. And I definitely agree that policymakers need to be aware of what people are taking and the difference between the synthetic and the natural products. And we need to regulate these kratom products just to protect us from ourselves. So thank you for calling that out. John, have you talked to anybody, any of your kratom patients, about the difference between the sort of kratom leaf and then the semi-synthetic, the hydroxymitragynine products?
I have not. And I'll be honest with you, this is a space I feel like I'm just entering, right? I feel like I've got a couple people.
Yeah, the gas station heroin space.
Yeah.
Well, that's all we got. Thank you for listening to the Addiction Medicine Journal Club. The best part of any journal club is the conversation, and we want to hear what you have to say. To have your opinions about the articles included in a future episode, please send us your comments on social media, email, or join our Facebook group. The links are in the show notes. Original theme music was composed and performed by Benjamin Kennedy. Audio editing by Michael Bonanno. CME support from My Cares. Produced by Dr. Patrick Beeman and Ars Longa Media. Addiction Medicine Journal Club is intended for educational purposes only and should not be considered medical advice. The views expressed here are our own and do not necessarily reflect those of our employers or the authors of the articles we review. All patient information has been modified to protect their identities. Thank you for being part of the conversation. Have a great day.